Good afternoon, hello, and good morning, everyone. My name is Steve Van Warmer, president of PAH Global Association. We're very excited to have you with us here today for On Air with PH Aware, our summer series of webinars that explores the remarkable evolution of pulmonary arterial hypertension from its earliest challenges to today's breakthroughs and the promising future of research and care. Whether you're a patient, a caregiver, a healthcare professional, researcher, or advocate, these live conversations offer insight into how far our PH community has come and where it is headed to next. And today we're really thrilled to have Dr. Vinicio de Jesus Perez with us to take us inside the world's leading PAH Centers of Excellence to discover how they're transforming patient care. Dr. De Jesus Perez explores the vital role Centers of Excellence play in advancing the diagnosis, the treatment, and the future of pulmonary arterial hypertension. Vinicio is a professor of medicine in pulmonary, allergy, and critical care medicine at Stanford University School of Medicine and a physician with the Stanford Adult Pulmonary Hypertension Program at the Vera Moulton-Wall Center of Pulmonary Vascular Disease. He also serves as Associate Dean of Stanford MD Admissions. He is internationally recognized in pulmonary vascular researcher whose work focuses on molecular and genetic mechanisms underlying pulmonary hypertension, pulmonary vascular remodeling, right heart adaptation and failure, drug and toxin-induced PAH, including methamphetamine-associated PAH. His research combines laboratory science with clinical trials aimed at translating new discoveries into better treatments and outcomes for patients and people living with pulmonary hypertension. Following the presentation, we'll have time for your questions, so please feel free to put those in either the Q&A tab at the bottom of your screen or in the chat for Dr. De Jesus Perez to answer at the end of his lecture. Finally, I want to give a big thank you out to our webinar sponsors today, Merck and Liquidia. Through the strategic use of innovative technology and compelling storytelling, your support helps PH Aware amplify the voices and experiences of patients worldwide, fostering a more informed and connected worldwide community. So without further ado, welcome to Global Centers of Excellence, Collaboration and Care. Dr. De Jesus Perez, thank you for being with us here today.
My pleasure. Can you see my presentation?
Yes, sir. Yes, sir, we can.
Okay, good. Well, good morning, everyone. And thank you to Steve for inviting me to be with you today. So today I want to make the case that pulmonary hypertension is not just a specialty diagnosis. It's a global health problem with very different faces depending on where in the world a patient lives. I'll walk through why it matters, what's driving the burden, where the care pathway is failing, and what a coordinated center of excellence-based response can look like. So let's start with the scale of the problem. Pulmonary hypertension, broadly defined, may affect up to 1% of the global population, and that can rise to roughly 10% of adults over 65 years of age, largely reflecting left heart and lung disease in aging populations. So PH as a hemodynamic finding is quite common, but pulmonary arterial hypertension, or PAH, is the rare precapillary form. It is the one for which more than 16 different drugs are currently available. In 2021, PAH accounted for an estimated 192,000 prevalent cases and 22,000 deaths worldwide. So let's put it another way. A rare disease is still responsible for tens of thousands of deaths a year, disproportionate to its prevalence, which is exactly why it deserves global health attention, not just subspecialty attention. The drivers of pulmonary hypertension are in uniform across the world, and that matters for how we design solutions. In high research settings, the dominant causes are what you will expect: left heart disease, chronic lung disease, and hypoxia, congenital heart disease, chronic thromboembolic disease, infections. But in low and middle income countries, there's a second largely overlapping set of causes that gets far less attention in the literature, like rheumatic heart disease, HIV, schistosomiasis, which is a parasitic disorder, sickle cell disease, tuberculosis, and high altitude exposure. These are not rare curiosities in the medical book. In some regions, they're the leading cause of pulmonary hypertension. Any global strategy that only addresses the first list is going to miss a huge share of the world's patients. So, where does the system actually break down? Well, 7 places, and they influence each other. Diagnosis is delayed. Symptoms are non-specific, so confirmation often comes years after the onset. Access to echo and right heart catheterization is limited outside major centers. Referral pathways from primary care to PH specialists are inconsistent or non-existent. There simply aren't enough PH-trained multidisciplinary teams, especially outside referral hubs. Even when a diagnosis is made, PAH-specific therapy is unevenly available, unaffordable, or not reimbursed. Patients outside North America and Europe are underrepresented in the trials and registries that generate our evidence base. And underlying all of this, we have sparse epidemiologic data from Latin America, Africa, Asia, and high altitude populations. So we're often designing policy without knowing the true shape of the problem in those regions. Individually, each of these seven items is a bottleneck. Together, they mean a patient's outcome still depends heavily on geography. Now, this is where centers of excellence come in. The idea is to create a regional hub that concentrates what individual clinics cannot sustain on their own: accurate diagnosis and risk stratification, multidisciplinary care teams, treatment access, structured referral pathways, registries, education and training, and participation in clinical trials. Accreditation models for these centers converge on the same 3 pillars, regardless of the region: early and accurate diagnosis, comprehensive treatment, and ongoing longitudinal management. The Center of Excellence isn't meant to replace local care. This is very important. It's meant to anchor it, giving surrounding clinicians a place to refer into and learn from. So what does it take to scale this globally? These are 8 priorities that I have identified. Building a hub and spoke network that connects centers of excellence to regional and community sites, rather than leaving each center isolated. To train local champions, frontline clinicians embedded in underserved regions who can recognize and triage PH early. Standardize diagnostic algorithms so they're adaptable to local resource levels, not just copied from high resource protocols. Expand telehealth so specialist expertise can reach patients who will never make it to a hub in person. Build global registries that are actually representative, not just convenient samples from a few countries. Support affordable, sustainable access to PAH-specific therapies. Diagnosis without treatment access doesn't change the outcomes. Make trial enrollment inclusive of the populations currently missing from our evidence base. And finally, invest in defining region-specific etiologies so we are targeting the causes that are actually driving PH where patients live. None of these are individually novel. In fact, all of these are things that are based on much of the work that we do when we evaluate a promising center of excellence. But going through my experience traveling to Latin America, to Africa, and other countries, I can tell you that these things that we take for granted here in our country and in many places in Europe are not really as reliably available. And so it requires careful thinking and strategic assessment of the resources and the expertise available so you can build a potential hub and spoke that can help a particular country to serve these patients. So right now, what's missing is being able to identify and put these 8 things together deliberately as a network rather than as isolated pilot projects. And that is the opportunity that is now in front of us. That's the end of my presentation. I'm going to stop sharing and give it back to you, Steve.
Yes, sir. Thanks, Benicio. So that's when you say that's the opportunity. So like that's the global opportunity for everyone. Who's going to spearhead that global project? you know?
Right. So I think this is why I believe we need to have local champions. We need to really make a connection with the public health representatives of each region, each country. So let me give you an example. Right now, I'm involved in helping establish a center of excellence in Puerto Rico. Now, Puerto Rico, we just recently learned from a recent epidemiological assessment that it's got over 7,000 patients with pulmonary hypertension. And that is only certain areas that have been served by the public uh, healthcare system. So there's likely others. Puerto Rico has a lot of cardiovascular and lung problems. So I'm sure that the numbers, if you even estimate, use the 1% number that I told you in the beginning, Puerto Rico has 3 million people, 3.3 million people. So we're thinking that there may be 33,000 people that are not diagnosed. So this effort is being spearheaded by the leader of the Pulmonary Hypertension Association chapter there, Sheila Alvarado. She contacted myself, the local pulmonary hypertension physicians, which include 2 individuals, and then myself. Since I'm originally from Puerto Rico, but also, I had experience seeing our pulmonary hypertension center from the very beginning grow where it is now and knowing what it takes. So to get this in motion, what we've had to do is uh, get together clinicians who actually see patients with pulmonary and cardiovascular issues and start talking with them, educating them. And also, Sheila has been able to reach out to the secretary of the health department to listen to our proposal. So I was able to help build a proposal for what the structure of a pulmonary hypertension center looked like using those 8 points that I just shared with you. Because I think you need to provide the lawmakers and the politicians a very clear path forward. Not only we need this, but how is this going to grow with time? How is this going to become profitable? And how is this ultimately going to increase attention so we can get patients to seek seek this in the Caribbean where there is really no PH group. So I think I guess it all boils down to, I think this is where a partnership with an organization like PH Aware that, helps educate and support patients together with physicians who are experts and who can commit time and effort into these enterprises. Uh, meeting with, meeting with politicians and those that are involved in budget allotment as well as laws and policies becomes ultimately, which means that it takes time. Not these things are likely taking time, but I think this is I have been always impressed by how passionate patients are, and I think if anything happens in any of these locales, is because the patients are the ones who are driving it. So I have nothing but respect for patient leaders because they're the ones who really take the lead in these initiatives.
Uh, Wonderful. And anybody attending here, again, put any of your questions in the Q&A tab or the chat function. Meantime, you laid out, these characteristics that you're striving for the best, highest performing programs. You mentioned various centers across the planet, Africa, Latin America, etc. Like, what are some of the most common characteristics of the best performing ones,
Yeah.
and conversely, what are some of the ones that things that they have a lot going for them, but they're like, God, they're really lacking this, if anything comes to mind.
So, I mean, let's talk about what distinguishes the highest performing programs. So, the best programs share several characteristics: experienced clinicians, rigorous diagnostic protocols, multidisciplinary decision making, dedicated nurses and coordinators, rapid access for deteriorating patients, and regular measurement of outcomes. They also integrate research education, patient support, and quality improvement into routine care. The centers that don't necessarily that cannot truly thrive, in my opinion, or who are uh, may not be as effective, are the ones who are isolated, where disciplines are not being are not being invoked, where collaboration is not part of the dynamic that drives the center, and those that certainly do not really work with patients to find common ground, to share that education and awareness. So I think any center that works in isolation is not a center that is going to be as effective in providing the necessary service to the patients.
You mentioned, the importance of multi-disciplinary care team.
Mhm.
I'm just curious if you could share, some of the who all is that involved. Maybe your experience at Stanford, how Stanford leads the way in that, as opposed to some of the other domestic or international centers that you see. So who needs to be at the table, if you will, on that patient journey?
Well, ideally, and this is based on the criteria for accreditation. So it's even so. This is definitely Stanford, but this is also what is being sought at when a center requests evaluation to become a center of excellence. But the core team usually includes pulmonary hypertension physicians, cardiologists, advanced practice clinicians, nurses, pharmacists, imaging specialists, and experts in right heart catheterization. Now, depending on the patient, it may also include rheumatology for those with autoimmune disorders, congenital cardiology, hematology, hepatology, genetics, obstetrics, addiction medicine for patients with methamphetamine, that's critical, social work, psychology, rehab, palliative care, and transplant specialists. As I said, the key word here is collaboration, which means that these professionals share information and make a unified plan with the patient. That is how centers thrive, when people communicate with each other and with the referring physician. So there are safeguards for information, preventing information from getting lost.
Just over over the years, PAH treatment has evolved so much, dramatically. And just in what you described there, in the addition of multiple multidisciplinary teams as they expand, what uh how has those experts helped in treatment of as the disease escalates, combination therapies, and how has that really just morphed over the years, I guess?
So I think for us right now, I mean, this field has now moved from the original paradigm of sequential therapy towards earlier combination therapy and more rapid escalation when treatment goals are not met. So high-risk patients may require parental prostacyclin therapy and early transplant evaluation, while newer treatments can be layered onto established pathways in appropriately selected patients. Now, the objective is no longer modest symptomatic improvement. It is sustained low risk status, preservation of the right ventricle, and now we're talking even about disease modification. So, but beyond medication, we also have to be aware that there are interventions that need to also be implemented. For example, supervised rehabilitation, appropriate physical activity, vaccination, oxygen when indicated, nutrition, psychosocial and financial support, and management of iron deficiency, sleep disorders, or other comorbidities. Includes other things that need to be managed: pregnancy, contraception, genetic counseling where appropriate, substance use support, advanced care planning, and transplant or palliative care consultation. So you see that as a comprehensive center, it's not just like deciding how to treat a patient, it's also taking into account the context, the circumstances that can influence how the patient's journey and how they will respond to therapeutic interventions will be influenced, right? A case in sample is I can tell you of a methamphetamine patient who's an active methamphetamine user, gets diagnosed with severe pulmonary hypertension. That patient likely will require aggressive therapy if they have advanced disease, functional class 4. But we cannot forget that this patient is still using methamphetamine, which obviously is the trigger here for the disease. So this is something for which I rely on my addiction specialist to actually work with the patient. It's something that I cannot do, but I am aware of that, this is definitely going to be a part of the care. So I can provide that, and my social worker can engage with the patient to assess their psychosocial status as well as identify the resources that the patient will need to continue the medication once they are discharged. So you see, it's more than just offering the advanced therapies. You need to holistically see how you can take care of this patient, as a whole. So as a physician, I understand what I can offer, but I also know where my limitations lie, and that's why working at a comprehensive center where I have access to multiple colleagues with different complementary disciplines comes to play.
Let's talk a little bit more about how what role the patient plays in this whole journey, and within a center of excellence. So just let's talk a little bit about shared decision making within this whole interdisciplinary team, uh, how important patient education is, or adherence to compliance to the therapies, quality of life outcomes, etc.
Sure. The patient is a member of the treatment team. It's not just simply the recipient of its decisions. Shared decision making helps align therapy with the patient's goals, tolerance for risk, lifestyle, reproductive plans, and ability to manage complex treatment. Now, education also helps patients recognize deterioration early, adhere to therapy, and participate more confidently in their care. So, and this is something that I discuss with colleagues in the pharma industry. Now, if you just stick with the clinical trials and the studies, you probably will want patients to be on, if you have somebody who fits the high risk profile in a Reveal 2.0, that patient should be on a parenteral prostacyclin along with orals, like triple therapy right there from the get-go. But the thing is that if I sit with the patient and tell them, like, you need to do this, the patient is likely going to be feel threatened. They're going to feel very uncomfortable. And most likely, they're not going to really engage with the treatment, nor will they establish a contract based on trust with our center. So shared decision making for us is critical because we will we will explain all the options to the patient. So yes, parenteral is what the guidelines say. However, a patient may not want to be connected to a pump, but they want to receive therapy. So I have to present the patient with those options, but also be transparent about what to expect in terms of benefits and side effects. I provide a recommendation to my patients on account of, like, listen, based on where you are at with your health, I think this is what you need to do. However, you could also try this, and these are the things that we need to watch out for in terms of deterioration. These are the side effects. I do think that educating a patient is half the battle. A patient that understands the direction that their care is taking will be an informed customer, and they will be empowered, and they will be more likely to stick with the medication, be compliant, communicate with our group to answer questions or deal with side effects. That level of support and trust is really important. So in my case, I have learned to trust patients. I may not necessarily agree with their choices based on, if I'm wearing my scientific hat, I could potentially disagree with, why are they choosing this drug when this other probably has a greater clinical benefit potential. But on the other hand, my role is to support the patient and provide them with options to improve their quality of life and live a longer, healthier life. And I think patients appreciate that, and that's why they're able to come back, and we're able to retain them for the duration of the care that they deserve.
Awesome. As a reminder to attendees here, please, if you have any questions, throw them in the chat function here. Continuing, Vinicio, on that, patient, doctor-patient collaboration. Let's talk a little bit about Global Centers of Excellence. Are, as you mentioned, are clinical research hubs. Uh, you know, Tell me a little bit about how you approach the clinical trial conversation when you see a patient in your clinic, and how you determine rather if they should be right for a trial. Is it because, like, hey, this could be better? Are they declining? Is it something to do to help them get to a better quality of life? How does that conversation come up?
So, as a center of excellence, we are heavily committed to improving our patients' quality of life and outlook. We understand that medications may work for some patients, but not for others. Very recently, in the last couple of years, we have started talking about patient phenotypes. So, in other words, a patient with a diagnosis of PAH that receives two patients with PAH receive treatment, one may respond great, another not so great, even though the numbers in the catheterization look the same. So what are the other variables that we are not really accounting for? Genetics, environmental exposures, race, ethnicity, ancestry. There's a lot of variables that we're trying to understand now as part of these bigger studies. We call them phenomics that try to integrate every piece of information. And so far, we're learning a lot of the hidden nature of pulmonary arterial hypertension, what makes it complex. So um, I think recognizing that patients, this we need our field is moving forward so rapidly, and there are all these opportunities uh, to come up with better treatment paradigms. Our group very carefully identifies opportunities for partnering in research. That includes working with pharmaceuticals, but also we have investigator initiated initiatives. That means that they're coming from with support from the NIH, or they're being funded independently. And what we're looking for when we want to engage in a clinical trial is we want to, number one, make sure that the science is solid, that the safety profile of an intervention is uh, is acceptable. And also, we want to ensure that patients will receive access to these medications beyond the duration of the study. And I think this is something that's critical at a global level, where patients who may participate in a study after the study is over, well, those patients deserve to be on a therapy, especially if the therapy if it's a positive study, they should continue, through an unlimited amount of time. They should not just be stopped when the trial is stopped. So for us, the first thing is we need to trust the sponsor. We need to review the protocol very carefully and make sure that the protocol have all the safeguards necessary to protect the patient participation. Only then can we sit down with a patient and invite them. Now, our criteria for exclusion inclusion are very clear. So we will identify patients on account of whether they meet these criteria, and then engage them when they come visit to discuss the trial, answer their questions, and ask their interests. We don't ask them to sign right then and there, but we give them enough information and we provide them with communication access so that they can come back and discuss. Again, I think engaging the patient requires establishing trust, and we're very lucky that we have been able to build a community of patients that remain with us for years. So when we come to them and tell them about a clinical trial, and that we feel like this is something that will benefit them, starting from that bond of trust, the patient is already open to listening to this and to potentially committing. And I think we've been very blessed in terms of being able to fully recruit for most of the studies that we have participated, just because our patients are so eager, and they also, again, the being a center of excellence, and us being able to share our research, our discoveries, also provides an air of legitimacy to the work that we do, which again is important, since then community leaders may refer patients to us so that we can consider them for our studies.
Can I ask you some of the top line, kind of the biggest questions that patients usually come back to when you
Mm.
approach them with that, or maybe even some of the biggest misconceptions that they may have when they're inquiring about participating?
Sure, I think patients they they're afraid of being guinea pigs. That's top, and I think that's a universal response. And I mean, you have to understand. I mean, it's when we're presenting a clinical trial, we're telling them, well, we don't know that we're going to be giving you actual drug. We don't know if this drug is going to work. What we have is evidence from maybe animal studies or phase one studies where we've treated healthy people just to see the toxicity profile. But this is it. This is gonna be a journey, and we are definitely going to take it with you, but then you need to commit to be coming in to at the requested timeline so that you can come meet, we can capture data, we can look at you, make sure that you are safe, healthy, answer all your questions, etc. So when you commit to a clinical trial, you're committing to a you're committing to a process. It's a journey. You have to you're gonna be busy, heavily involved. So that's why we have to be very transparent with patients. So I mean, for most patients, they feel there's an anxiety component about participating. There's also, other, issues that are not associated with the medication, such as like, I don't know if I can travel back and forth. I don't know if I can take time from work to do this. I don't know if I'm gonna have the money to support myself doing this back and forth. And this is where, of course, we have to, we do our best to help provide. I mean, that's why we ask our sponsors to help, cover or assume some of the responsibility for these things, because, we cannot ask our patients to, put their life on hold while they participate in this just based on the, on pure trust that, what they're gonna get is gonna work out and they're gonna help. So, I think we're being very honest with our patients. We're being very transparent, and I think, as I said, I think once you establish a bond of trust with the patient, and again, it's somebody that has been cared by our team for some time, so they know that we have a system in place that will care for them, will not let them fall through the cracks. I think patients, as long as they're able to ask questions and receive answer for them, they're able to make an informed decision. A patient that decides they don't want to participate, that's great. We will never push on a patient, and we will never say, in the future, we're not going to involve you anymore. On the contrary, I mean, again, these are things like I just want, even with new medications like sotatercept, for example, there are patients that they don't want to take the new medication because it's new, right? So, you have to respect the patient's concern, but, you're also, you're also responsible for continuing to engage and educate the patient, to make sure that, their perspective continues to evolve along the way. But, that's the best you can do without compromising the trust you have with a patient.
you know, um, referral patterns, are still a big barrier in care. When should a community clinician, a general cardiologist, a community pulmonologist refer a patient to a PAH potential patient to a center of excellence?
Yeah, so I think referral is appropriate whenever pulmonary hypertension is suspected and diagnosis is uncertain, right? I mean, if the symptoms are disproportionate to the heart or lung disease that the patient may have, or the echo suggests significant high pressure or right heart abnormalities, right? I think referrals should be urgent for rapid progression. Like, for example, the patient who starts presenting with loss of consciousness, severe right heart failure, a pregnancy, somebody with suspected chronic thromboembolic PH, or if the patient has been started on therapy and patient is really not doing well. I think clinicians do not need to complete the entire evaluation before referring. We're very clear that physicians should have a very low threshold of referring patients that they feel may require a pulmonary hypertension evaluation. In our center, again, we've been now in business for 25 plus years, and we do work very closely with community colleagues. We do our best to work, educate, and again, just like we build trust with our patients, we build trust with our community partners. When they refer a patient to us, we will take care of that patient. We will initiate therapy if that's what the referring physician wants, and but we will defer the rest of the care to that physician. But then again, hub and spoke. That physician, becomes the recipient of education support while they take care of this patient.
Yeah, that was going to be my next question of like, what do the community practices learn from you, and what do you in turn learn from them? But this hub and spoke analogy is pretty good.
Yeah. So, I mean, the Centers of Excellence provide diagnostic depth, advanced therapies, research access, structure risk assessment, etc. The community clinicians contribute continuity. They know the patient's social environment. They manage the other comorbidities. And most importantly, they're closer to their home. The strongest model, as I said, is this partnership in which expertise travels from us to the community physician and back. Because then the community physician who is taking care of this patient may say, listen, I have Mr. So and so here, and they're actually gaining weight. They look like they're in failure. So what do you advise? And of course, I will say, well, tell them to come here as soon as possible. But at the same time, I'm talking with a doctor who knows this patient, holistically. So I will say, listen, from what, let's have a peer-to-peer consultation. Let's discuss and let's agree on something that you can do right there, right now, so that, we can control the situation. Maybe we need to refer the patient to a local emergency room, and you as a physician are going to be engaged, and you're going to be, we will be happy to accept the patient, but in the meantime, you're the person there and we will be supporting you. So in that way, we feel that this partnership will benefit the patient outcome tremendously. And For us, we've been really blessed with having to work with excellent community physicians who really advocate strongly for their patients. Even, for example, when they need to be have procuring oxygen, or when it comes to dealing with insurance reimbursements, disability claims. So I think this is a real example of what true multidisciplinary partnership can accomplish.
It's great, all the therapies and the trials that led us to where we are today. But I think you'd agree that delayed and incorrect diagnosis is still a really huge bar in PAH. Is there any thoughts you have on how centers of excellence can help improve that early recognition, shorten the path to an accurate diagnosis, either within your center or within the referral partnership hub and spoke you were speaking of?
Yeah, I mean, I think centers can educate community clinicians about warning signs of pulmonary hypertension, like edema, inappropriate weight gain, syncope, orthopnea, chest pains. They should establish rapid referral pathways and provide consultation before every test is completed. Um, I think we should, as centers of excellence, we should also advocate for standardizing the evaluation of unexplained dyspnea and ensure that patients receive essential testing, particularly echocardiography, VQ scan when appropriate, and of course, right heart catheterization. Importantly, a normal or mildly abnormal early test should not end the evaluation with clinical suspicion remains high. This is the case, for example, in somebody with an autoimmune disorder like scleroderma, where the echo may look normal, but the patient is presenting with significant shortness of breath that cannot be explained by lung disease. Then you look at the pulmonary function test and you may see a low DLCO, which is a measure of how well the lung captures oxygen. And in that case, knowing how high the risk of pulmonary hypertension is with scleroderma, I will not stop on just looking at a normal echo and saying, oh, there's no PH. I will definitely want to take that patient through the diagnostic workup and even a right heart catheterization to convince myself that they don't have PH. And even if they don't, that's a patient that should be followed at least annually or every 6 months to a year to keep an eye on for the development. Again, the earlier you can catch these patients and treat them, the better is going to be the outcome.
We talked about all the pillars and all the things that are important in these global centers of excellence. Where Tell me a little bit about your thoughts on technology. Technology in medicine changes rapidly by the day. How do you see telemedicine, remote monitoring, AI, digital health tools kind of working in the PAH centers of excellence, delivering care in the days and years ahead?
Sure. So I think telemedicine can extend specialist expertise to patients who live far from major centers, while remote monitoring may identify deterioration between visits. Wearable devices, home measurements, digital symptom tracking may provide a more continuous picture of functional status. Artificial intelligence is something that I have been spending a lot of time thinking about and reading about and also implementing in my own practice. And I think AI could help integrate imaging, hemodynamics, biomarkers, and clinical trajectories. But again, and this is kind of my argument and that of our medical community at large, is that it should support and not replace expert judgment and the patient-clinician relationship. I think that is something that is very unique about how we care for patients. But at the same time, I cannot see the future without seeing a role for technology and AI in it. And I'm very optimistic that it's going to be there to help us provide better care for patients.
So in the model that you laid out, what lessons or what structure from that plan would you hope that every PAH program, whether it be local, community, domestic, would that you'd hope they
Yeah.
adopt?
Yeah, again, this is something that I spend a lot of time thinking with as part of my global PH initiatives in Latin America and in Africa. But, I think that a universal model, if you will be creating regional networks rather than isolated centers. Each network will combine an expert hub, train community partners, standardize diagnostic and treatment pathways, teleconsultation, connect with patient organizations, and then a shared outcome registry. The registry is critical so that you know how you are doing. The essential principle here is that geography and socioeconomic status should not determine whether someone receives an accurate diagnosis or effective therapy. Again, that's why I really like this model of hub and spoke, because it really, literally, I mean, when you talk about well-rounded, that's what I'm actually seeing. I put together all these elements, patient advocacy, government, regional care, and education. And I think education it's a right. It's something that can easily be shared. So without education, you're not going to have, effective advocacy, or you're not going to be able to go to the government and ask them to pay for a new medication to be included in the universal health plan, or pay for a catheterization when rather than just depend on an echo. So I mean, I think this is the most important thing that we can provide. And as I said, education has no boundaries, which is why for me, being able to travel, interact with colleagues across different parts of the world, learn about their practice, the kind of patients that they deal with, and the access that they have becomes part of, like, okay, so let's just establish the groundworks for what could reasonably be accomplished, with our help.
Wonderful. Well, I thank you, bless you for the work that you do and all your colleagues there at Stanford. That was basically the questions I had for you, Vinicio. Unless that's a pretty good final word, I think. Unless there was anything else you wanted to say.
No, I think this has been a great experience. Thank you so much for organizing, Steve.
Awesome. Let me just do one little moment of housekeeping for all folks that are still online here. Let me just see where that is. Uh, 1 second. I have to open up another tab, everybody. If you can give me 10 seconds here. One moment. What I was going to say is I want to thank you for joining us here today. I think I can get this tab up here. Hold on a second. One moment, everybody. I apologize. I'm doing two things at once here. Well, nonetheless, I was going to say it without sharing my screen. We have one more planned webinar coming up on September 15th with Gene Elwing. This is Clinical Trials Matter, the Backbone of Innovation. So we hope you will join us for that on Tuesday, September 15th, 9 a.m. Pacific, 12 p.m. Eastern. Again, thank you for everyone joining here today. We're gonna put a playback of this on our PH Aware social media and on our HeartWorks app. And if you haven't got HeartWorks app, you can go to phaware.global/HeartWorks to learn more about that. So, Vinicio, thank you so much for being here today, and we will see you next time. Thanks, everybody.